this Telovelar approach. Tom.
Thank you very much. So it's going to be a little bit of a anatomical and focused talk. This can be used in approaches to cavernous malformations. In fact, it's only a minority of them that we will approach through the floor of the fourth ventricle, but lots of other particular tumors, particularly in children, happen around this area. And because it's such a common and useful yet commonly misunderstood approach, I thought it would be worth going through it. And I'd like to pay my tribute to Dr. Roton, and would like to quote his statement that I put on the wall in his office to make the delicate, awesome, and faithful work of a neurosurgeon more accurate, gentle, and safe. I'd like to also acknowledge Professor Ribas, as well as Ramez, on the background of a Cambridge college some time ago, and you may want to read all of the gentlemen's books. With regards of this particular talk, I would recommend this book, from which I have taken a number of illustrative anatomical dissections. Many of them were done by Dr. Yagmurlu. Now, why do we need to know all there is to know about how to get into the bank, and particularly how to get into the safe, but also how much money to take and how to get out without getting caught? We've heard of the various approaches to the brainstem, and we'll excuse me, focus on this suboccipital approach, and in fact one specific midline suboccipital version of the approach in order to expose the fourth ventricle and deal with whatever lesion we have to deal with. So let's understand fourth ventricle. Well, fourth ventricle is, well, ventricle means a room in the Roman villas, as I'm sure Professor Brogi would say it's true. So the fourth ventricle is the last chamber, the last room before the CSF leaves the intraaxial ventricular space through the foramen Magendie into the cisterna magna, and through foramen Alushka into the cerebello-pontine and cerebello-medullary, in particular, cisterns. The fourth ventricle has floor, roof, and lateral recesses, and we'll go through that in more detail, because it's worth knowing what is around the lesion that we're dealing with. Primarily, the surgery is not about cavernoma, it's not about tumor, it's about the patient, and brainstem is an important part of the patient, which hopefully will leave intact, will get in, get the money, get out without damaging the whole street. So the floor of the fourth ventricle pretty much has most of the cranial nerve nuclei and connections underneath. And it's worth to have some sort of scheme. So is the upper third, middle third, and inferior third. The upper third of the ventricle is triangular shape, and it's kind of pretty much from the entrance into the aqueduct superiorly to the upper part of foramen Alushka, which is kind of this way, and we'll understand more and more as we go through the talk. And the inferior triangle is from Obex, or the calamus scriptorius, here until the upper attachment of the tila choroidea onto the lateral aspect of the cerebellar floor, particularly the beginning of the inferior cerebral peduncle, but we'll be talking about it later on. So in the midline, we've already heard we have the median sulcus, and there is nothing particularly magical about the median sulcus. It's not really a place that we can just open because it's there. It's important to realize that right next to the median sulcus run all the fibers that connect horizontal eye movement. Yeah, so that there's a nucleus around sort of here, paramedian reticular formation, which then connects with a facial nucleus deeper down, and sends fibers to all the ocular motor nuclei in the midbrain. So, and it's running right next to the median sulcus. So pretty much if we, right underneath the ependyma, so if we play with it, we end up with internuclear ophthalmoplegia with damage on both sides, very complex eye movement problem that pretty much is going to stay with the patient for the rest of his or her life, and it's uncorrectable. So it's worth keeping this in mind when we're planning the bank robbery. So then we have the collateral sulcus or sulcus limitans, and between the median sulcus and sulcus limitans, we have most of the motor nuclei lined up, including facial nucleus and hypoglossal nucleus, and then the dorsal vagal nuclei. So it is also worth having some sort of organization of that. In the median part, we have vestibular nuclei and cochlear nuclei, dorsal and ventral. The cochlear nuclei are slightly more laterally. Other sort of feature that is worth knowing is superior fovea, and knowing the boundaries of the superior fovea, at least roughly, is also worth knowing, because the superior lateral boundary of the superior fovea is made by superior cerebellar peduncle, which we'll be talking about a bit more later on. At the apex of the superior fovea, if we excuse me, connect the apices with a line, and then we can see where the facial colliculus is. I mean, now, for example, on this picture, although it's not 3D, we can pretty much make up the facial colliculi here, but sometimes it's not as obvious. But maybe there'll be the superior fovea that will be more obvious. So it's nice to have various ways of identify what's going on. On this picture, which is kind of a lateral view, we can again see the median sulcus here. We can see the sulcus limitans laterally, and we can see the motor nuclear column running right in the middle. That's the inferior fovea here. And again, that's the superior fovea, triangular superior fovea. So we'll know that if we connect this apex with this apex here, the underneath the line in the medial eminence, which is this column called here, we'll have facial colliculus here. Now we have this stria medullaris ventriculi quarti in Latin, or stria piccolomini, which are always very dominant feature here. And lots of people are wondering why they're there, you know, what sort of fibers are running underneath. They're usually asymmetrical as well. So this picture from a paper, I can't remember, this is like a 1940s or even older paper. You can see the black and white illustration here. So these are the fibers running from the arcuate nuclei, which is kind of at the very sort of tip of pons stroke medulla, and they run in the midline, and they go on the other side and run into the cerebellum via the inferior cerebellar peduncle, which is here. That's the same sort of system as the pontocerebellar fibers. So nothing necessarily magical about it. This picture is here for us to realize what's underneath, kind of when we look at it from the top, but also how deep in the brainstem the various lesions are. So we can see the facial colliculus here, and we all know that the actual prominence here is not really caused by the nucleus of the facial nerve, which is deep down, but by the nerve fibers that wrap around. We'll see it on the dissections bit more better later on. We can see the hypoglossal, we can see the hypoglossal nucleus, we can see the nucleus ambiguous, and this is the nuclei from from which hypoglossal nerve fibers come, so that control the branchial muscles, such as muscles of the palate and throat and so on. So they're responsible for or helping us with speech, swallowing, protection of airways. So it is not very common when we play on the surface of the floor of the fourth ventricle that will cause that. It usually happens when we damage the nerve roots of the hypoglossal nerve, particularly bilaterally, but even unilaterally. But of course, depending how deeply a particular lesion on the floor of the fourth ventricle goes, we can cause damage of that. So if you look at it mediolaterally, I've forgotten to say that, here would be the superior fovea, and in the sort of superior aspect of it, just underneath the superior medullary velum, we will find the main motor nucleus of the trigeminal nerve, and the facial is deep down around the abducens, and the facial fibers will be running around here. Then we have the salivatory nuclei for 9 and 10, and here is the nucleus ambiguous, the main sort of part of the vagus nerve that we're concerned about. And on the right side, we have the sensory nuclei, nucleus structus solitarius, and then the principal sensory nucleus of the trigeminal nerve. As we know, the facial sensation is in the mesencephalic nucleus and tract, and then the pain and temperature running downwards in the spinal nucleus. So let's have a look at some dissections now that we know how it works. So that's your abducens nucleus, and that's your proximal and distal loop of the facial nerve. Here is again the median sulcus, and just lateral to that and very superficially run fibers of the medial longitudinal fasciculars that I mentioned earlier, that connect the reticular formation of the median paracentral pontine reticular formation, the deep down located facial nerve, abducens nucleus, and the nuclear oculomotor nuclei in the mesencephalon. Here, once we are talking about this dissection, we can see the trigeminal nerve here. So again, that's the facial colliculus here. Here is our superior fovea, and here would be somewhere located deep to that the principal motor nucleus of the trigeminal nerve, i.e. here, and the fibers then join the trigeminal nerve coming anteriorly from the pons and central tegmental tract, which we're not going to particularly spend too much time on it. We already said that hypoglossal nucleus would be located about here. The vagal nucleus would be here, but we're talking about the dorsal vagal nucleus. And dorsal vagal nucleus is the bit that controls the heart and cardiovascular sort of systems and gastrointestinal system. Generally, if we were to damage it unilaterally, not a lot would happen. Pretty much nothing will happen. If we, of course, damaged this area and this area really badly, this could have fatal consequences. So we're right not to fool around in this area too much. So there's again this area. If we kind of zoom in, we can see what we talked about. That's the actual nucleus of the 7th nerve. That's the proximal loop, distal loop, and that's the abducens nerve with its fibers going straight forward to come out on the anterior aspect of the pons. And this is again the spinal tract of the trigeminal nerve, and that's the trigeminal nerve going forward to come out from the pontomedullary junction. We have already seen that, just perhaps a little bit more lateral again, facial nucleus, if you're interested exactly where it is, and that's your right-sided MLF, that's your left-sided MLF. You play with it, the patient will have diplopia, full stop. Again, to sort of appreciate this facial colliculus superior fovea, but with the interest of time, I'll move on. Perhaps just to point out again the sort of sections, which is often good to realize how deep certain things are. So again, acute nuclear, that's your stria medullaris ventriculi quadripicolomini, and just out of interest, the ambiguous is about here. So we're now at the so lower medulla, ambiguous of the so lower medulla stroke pons would be about here. So there's the olive with various accessory olivary nuclei, and ambiguous is about here. So that's the tracheostomy peg disaster zone, right? Just out of interest, that's your hypoglossal nucleus, it's right out right next to the midline, and dorsal vagal nucleus. Again, if it's damaged unilaterally, probably not a big deal would happen. Control of cardiovascular system in particular. So we'll talk about lateral walls now, and lateral walls inferiorly are caused, formed pretty much by inferior medullary velum, which we'll talk about with the roof, and in the superior half by the inferior cerebellar peduncle. So let's talk about peduncles. So this is a superior cerebellar peduncle. Ramesh already showed this slide, and we can see so superior cerebellar peduncle, as you know, is main output from the cerebellum going upwards towards the telencephalon, and the output comes from the nuclei of the cerebellum, which this big one is our dentate nucleus. Remember the mnemonic, don't eat greasy foods, yeah? So dentate, globose, fusiform and emboliform nuclei of the cerebellum. So that's the superior cerebellar peduncle. If we add to it, which has been removed, superior medullary velum and close the hole here, we will have the roof complete there. So there's a view from the lateral, again, dentate nucleus and the outflow fibers going in the upper part of the roof, in the lateral aspect of it, into the midbrain, and then just go in front of the aqueduct and the cross in the
Tom, 2 minutes. Tom.
2 minutes. Oh my gosh. So we need to speed up a little bit. Just showing that's the middle cerebral peduncle, that's the inferior cerebral peduncle, that's the superior cerebral peduncle on a cross section. So it's really the superior cerebral peduncle and inferior cerebral peduncles that form the lateral wall. I think we will just skip the embryology now and just discuss some of the parts of the roof, which is the essence of what we want. So if we're looking from posterior, there's the dorsal part of the neural tube has nothing here. It's been completely perforated. Higher up, it has telechoroidea, which is the junction of the ependyma and pia. Higher up, there's a bit of neural tissue, which is the inferior medullary velum, and which connects the nodulus with the flocculus. So we can all open it, and once we open it, we have entrance to the floor of the fourth ventricle. I'll skip that. The vascular anatomy, as relevant as it is, and just take you through how I do this surgery on the fourth ventricle. So usually in prone position, and it's important to fix the head in the mostly atlanto-occipital joint, which will not only open the foramen magnum C1 part, but also will allow us to look down into the fourth ventricle better. So we have various maneuvers to do. So there's a flexion in the atlanto-occipital joint, there's an additional flexion in the neck, and then we elevate the whole patient into kind of towards the sitting position, as Professor Kanan mentioned. And of course, we always strap the patient. If we operate from one side, mostly we'll position the patient a little bit asymmetrical, which is kind of for our back if you operate from this area here. So if we do the craniotomy, make it a little bit smaller, so just the blue area, and open the cerebellar vermian fissure, which actually really we can do during surgery.
1 minute now, Tom.
Can be very deep, and basically it will open the whole fourth ventricle to us. If it's okay, I'll do this quick video which actually shows it on the patient. I'll skip this story.
Yes, please.
Of the video, and so we have feet here. That's the head here, spreading tonsils, and you can start seeing the tela choroidea, which we can cut with the choroid in it. So all the vessels that come off pica here, choroidal vessels, so we can bipolar and cut them all. We can do it on both sides,